Moving into traction as a therapeutic modality and treatment for some specific syndromes or injuries. This is what a typical traction table looks like. A few things to point out. We have two belts. One will stabilize the patient for lumbar traction, and one is hooked up to the motor unit to pull down. Note at the positioning, the ideal positioning with the legs and knees, or hips and knees bent. Pillow under the head, and then the safety control here. If your patient is claustrophobic, this can be kind of a freaky thing. So you may get somebody set up and they just can't tolerate it because it makes them feel closed in. These have to be really tight when providing the traction, or else they'll slip. All right, what are we using traction for? Typically, it's a spinal dysfunction, and oftentimes we're have a diagnosis of a bulging or progressed into a herniated disc. So typically what this looks like here, we have our normal disc with the nucleus pulposus and the annulus fibrosus around it, and the pulposus has been pushed through the fibrous annulus, or the annulus fibrosus, and is pushing oftentimes then on a nerve root. And wherever this nerve goes is where the patient will experience symptoms of tingling or ache or pain. Here we see an example on CT scan, and you can see the herniation right here. Sometimes we'll see a diagnosis of degenerative joint disease, DJD. So as you age, this is just common aging of our vertebrae. We'll see that these end plates, or these ends of the discs, begin to degenerate. And when it takes place in the joint, or the facet joints, then it's called degenerative joint disease, or DJD. There's a lot of terminology. Sometimes you'll see or read a diagnosis as a disc herniation, or a disc bulge, or disc prolapse. This is the common terminology. So if we have a normal disc here, and then we have a little bit of degeneration of the disc, so we see it moving out. If it's gone beyond a circular position, then it's prolapsed, and it's at the extrusion state when it's about ready to come through. There's not much annulus fibrosis, and then it's a sequestration when the disc has actually gone, where the nucleus has come completely out. So the terminology can be confusing because these terms are interrelated. If they say like a bulge, you don't know if it's this stage of a bulge, or an extrusion stage of the bulge, or herniation. So you might have to contact the doctor and find out exactly, or as you go through rehab, that may show itself. A reminder what a facet is. The facet is where the bony on bone comes together, and then it's surrounded by a capsule. This is highly innervated. So know that when somebody has low back pain, it's very difficult to know if it's coming from a disc, if it's coming from the facet, if it's coming from a pinch on a nerve root. You may see nothing on MRI, and they still may be experiencing a lot of pain. Or it can go the other way, and you see a degenerated facet joint here, and you can't believe that they don't have pain there. Maybe the pain's located somewhere else. But it's a difficult area to try to find the source of pain. Another term is degenerative disc disease. We said degenerative joint disease, but degenerative disc disease is when the disc begins to wear down, and so it's lost its water content over time, years and years, and so this foramen can become narrowed and impinge on a nerve. So another thing that can take place. So traction, what we're really trying to do is separate, distract one vertebrae away from another, increase the spinal foramen space, decrease the loading on the back, on the disc, and decrease some of the pressure and hopefully the pain. So in your notes, there is a list of contraindications for both cervical and lumbar spine, and then I'm going to add these in under cervical spine. you'll watch a video, if you haven't already, on a vertebral artery test. If that test is positive, we will not do cervical traction. And also the alar ligament test, if that test is positive, we will not do cervical traction. For the lumbar spine, we'll not do traction. If there's anything on the list for both contraindications, as well as then add on if they're pregnant, because there's a significant increase in ligament laxity throughout the body during pregnancy, so it's contraindicated to use traction. I probably would use, maybe I could use some mild traction, but I certainly wouldn't use mechanical. If they have a peptic ulcer or abdominal and hiatal hernia, wouldn't use traction. Here's a picture of manual cervical traction, just to note that we can vary where the traction is, what part of the spine. When we have them in neutral position, our traction is taking place at a little higher in the cervical spine, and then when we put the person into flexion, then the traction pole is directed a little bit lower down in the cervical spine. That's manual traction. We can do the same thing with a mechanical cervical traction table. So if you raise this table up so it's pulling more at a parallel position, that's the upper cervical, and then if we have it down in this position, we're about mid to lower cervical traction. This is a unique home unit that's pretty popular. So if you find that manual traction is helpful, you might want to show the patient what's called a pronex cervical traction. They can do this traction on their own. And it's kind of like a blood pressure cuff, and you just squeeze the bulb, and it inflates the bellows and provides some traction on the cervical spine. It's actually very comfortable. A Saunders cervical traction is another one. And kind of the same idea. You use this, looks like a bike pump, and then it pulls the sliding tray kind of up. This one, though, the head tends to come forward a little bit, so they have to have a strap. And I don't think this one is as comfortable as the Pronex. But already showed you this picture of mechanical lumbar traction done in a supine position. We will talk about positional lumbar traction, where we do a rotation. Actually, we bring the hips forward and the shoulders back, but we are in sideline, so we'll show you when those are indicated and talk about that in lab. Mechanical traction can also be done prone, so especially if somebody's got a disc that's prolapsed posterolaterally and well, maybe not prolapse, maybe just a little bit of herniation, not completely extruded out. This is a great position, and then we add traction into it. You'll find out later in therapeutic interventions too that this is a position of exercise and that we utilize oftentimes with disc patients. This is kind of a funny one, but again, this one was a home unit over the door cervical traction. And however much weight you put in here, that's the amount of pull that will be distributed through the traction unit. Again, that's only one modality that you can utilize for disc problems or degenerative joint disease in the low back. But this, I just wanted to make sure that you know too that there's exercises, and this is often one that's used in the low back, a knees to chest, single knee or double knee to chest. We'll talk about the appropriateness of those when we get into therapeutic interventions too. But there have been some studies that show that no matter what traction you use in the low back to unload, when the person stands up, they're going to load that again. So the results that you get from traction might not be sustained at all. However, I am a big proponent of just decompressing the body frequently. So I think that any traction, if you can get somebody to decompress for 20 to 30 minutes a day, is in general going to be helpful.